So this is part 2 of chapter 2, and we're going to start with cerebral palsy. Cerebral palsy may be congenital or it could be acquired. It could be bilateral or unilateral. Cerebral palsy is a condition consisting of a group of disorders possibly involving the brain and nervous system functions that deal with movement, learning, hearing, sight, and thinking. Most times CP is suspected during routine well baby or well child visits. Cerebral palsy affects primarily motor performance, and there are 3 types. There's spastic, that's characterized by hyperactive reflexes or rapid muscle contractions. There's athetoid, which is characterized by involuntary muscle movements, especially during times of stress and reduced muscle tone. And then there's ataxic, and that's characterized by lack of control over voluntary movements, poor balance, and a wide gait. A patient may exhibit signs of all 3 types in varying degrees from mild to severe. Cerebral palsy usually stems from inadequate blood or oxygen supply to the brain during fetal development, or during the birthing process, or even in early childhood. Early treatment helps the child to reach optimal accomplishments, and also to minimize the handicap by providing every possible therapeutic measure to help the child. Some notes here for you. Most insults to the brain result from an interruption in the circulation of blood to the brain during labor and delivery, or from infection or head trauma during the first month of life. Diagnosis is made from the clinical picture and neurologic examination findings. There is no cure for cerebral palsy, and physical therapy, speech therapy, and special education may be required for this child. Orthopedic intervention with casts, braces, and traction or surgery may also be indicated. And we want to reinforce the fact that there is no cure for cerebral palsy and that parents should take advantage of the support services that are available to them in their community. Muscular dystrophy is next, and it's a progressive degeneration and weakening of the skeletal muscles where fiber muscles are abnormally vulnerable to injury. There are several types of MD, and all of them are rare. The most common and best known type of MD is Duchenne's. Muscular dystrophy initially affects the muscles of the shoulders, hips, thighs, and calves of the legs. These affected muscles sometimes look larger than normal because fat replaces the atrophied muscle. The child also may have lordosis or other spinal deformities, so they may have hunchback or other spinal deformities, and MD is usually first suspected during routine well baby or well child visits. As this disease progresses, it involves all the muscles eventually, and that causes crippling and immobility. So these kids may start off looking fairly normal children, fairly healthy children, and then you will see a definite and definitive progression with MD of kids who will eventually lose their ability to walk and to have major motor functions. MD is caused by the absence of dystrophin, which is a protein involved in maintaining the integrity of the muscle. The MD is the cause for hemophilia and color blindness also. The disease affects only males and is generally inherited through female carriers. So that's a little known fact that MD only happens to male babies or to male children, and usually their mother or female carriers are responsible for passing it on. So characteristic symptoms along with family history of MD suggest the diagnosis. Muscle biopsy and electromyography confirm the diagnosis. There are no known successful treatments for MD. However, we can provide physical therapy, exercise, surgery, and the use of orthopedic appliances, which can minimize deformities and preserve mobility. The prognosis, unfortunately, for a child with Duchenne MD is poor. This child usually is confined to a wheelchair by the age of 9 or 9 to 12 years old. Spina bifida is a condition where the posterior portion of the bony canal containing the spinal cord is completely or partially absent. And this is due to a failure of the posterior spinal processes to close. There are 3 types: occulta, meningocele, and myelomeningocele. These are also often called neural tube defects, so be aware of that. You may hear them referred to as neural tube defects. And this failure of complete closure allows the meninges and, in severe cases, the spinal cord to herniate, which is never a good thing. So, spina bifida occulta involves posterior arches of the vertebrae that fail to fuse, but there's no herniation of the meninges or spinal cord. Most cases are discovered during a newborn examination, so shortly after birth. Spina bifida occulta is sometimes asymptomatic, meaning it has no symptoms at all. But at other times, the only evidence of a neural tube defect is dimpling, a tuft of hair, or a hemangioma over the site where the vertebrae have not completely fused. The etiology of this congenital anomaly is unknown. It's thought that reduced levels of vitamin A and folic acid consumed during pregnancy may contribute to the incidence of spina bifida, though, and diagnosis is usually made by prenatal ultrasonography or by postnatal physical exam, detection of neurologic symptoms, visual inspection of the spine, and then spinal ultrasound also. Usually, spina bifida occulta requires no intervention other than observation, but the treatment will depend on the degree of neurologic involvement. So let's move on to meningoceles. The meningocele is when the meninges protrude through an opening in the spinal column, forming a sac that fills with cerebrospinal fluid. The sac is formed over the defect, and that permits the passage of light during transillumination. So the exact cause of meningoceles is not known, but surgical intervention will correct the defect. Most cases are discovered during the newborn exam. Diagnosis can be made by visual examination of the spinal area and verification of the presence of a sac. Radiographic studies of the spine confirm the clinical findings, and then because the spinal cord is not involved, paralysis usually does not occur, so that's a good thing. Because of the etiology of this condition is unknown, methods of prevention are also unknown. A myelomeningocele is the most severe form of spina bifida. It's a protrusion of a portion of the spinal cord and meninges through a defect in the spinal column. This condition is very apparent during the newborn examination. You can visibly see the condition. Infant may have musculoskeletal malformation, immobile joints, or paralysis of the lower extremities. The etiology may include genetic factors. Spinal cord defects are more common when prior offspring of the mother have had a similar defect. Neural tubes fail to close during fetal development, and that's what causes these myelomeningocele. That's a mouthful. Diagnosis is made by physical examination and imaging, and an EMG is going to be used to determine the extent of neurologic involvement. Treatment for myelomeningocele is surgical intervention. Hydrocephalus is where the fontanelles, which are the soft spots, people know them commonly to be called the soft spots on a baby's head, begin to bulge. The sutures of the skull separate and the scalp veins become distended. So you may or may not be aware that when a baby is delivered vaginally, what happens is their skull bones collapse almost one over another. So they fold down so that the baby's head can get through the birth canal. And then they set back up. And where they set back up after birth and they fuse together, the parts where the bones folded down for birth, those eventually harden up. And those points of fusion for these skull bones are the sutures. And so with hydrocephalus, the soft spot, in fact, the soft spot is where the bones have come together but have not developed and ossified all the way yet. So when a baby has hydrocephalus, those soft spots will start to bulge, and that's causing the sutures of the skulls to separate, which means that their bones aren't going to join together the way that they're supposed to. So head circumference increases at a faster rate than expected with babies that have hydrocephalus. In hydrocephalus, the amount of cerebrospinal fluid is increased greatly, or its circulation is blocked, which results in an abnormal enlargement of the head and characteristic pressure changes in the brain. So that's a big deal. The infant has a high-pitched cry, is very irritable, and may have episodes of projectile vomiting. Many cases of hydrocephalus are apparent during newborn exams, while others may be detected during well-baby examinations. As far as etiology goes for hydrocephalus, An impairment of the circulation of the CSF and the ventricular circulation may be caused by a lesion within the system or by a congenital structural defect. An impairment of the flow of the cerebrospinal fluid in the subarachnoid space prevents the CSF from reaching the areas where it would normally be reabsorbed. Diagnosis is going to be made through the clinical picture, physical examination, and radiographic skull studies. So we'll take x-rays and MRIs and CTs of the baby's brain, and then be able to piece together the clinical picture along with their physical exam and diagnose. Treatment is going to consist of surgical intervention to place a shunt in the ventricular or subarachnoid spaces to drain off the excessive CSF. These one-way valves will help to shunt the excessive cerebrospinal fluid away from the cerebrospinal canal, and that helps them maintain a normal pressure in their brain. If hydrocephalus is left untreated, the increasing intracranial pressure of hydrocephalus causes mental retardation and eventually will cause death. Prognosis for these children varies depending on the extent of the condition as well as the success of corrective interventions. Most children can function normally in society, so that's the good news as long as there's treatment provided. The bad news is there's no prevention known for the congenital form of hydrocephalus. Anencephaly, I almost hate to go through this condition because it makes me incredibly sad. Anencephaly, and the anencephalic fetus, anencephalic, I'll get this right one of these days, fetus or neonate has no cranial vault and little cerebral tissue. Etiology is essentially unknown, but it's characterized by failure of the neural tube at the cephalic end to close completely, and there is no effective treatment. This is the most severe form of neural tube defects, and it occurs early in gestation with failure of the cephalic aspect of the neural tube to close. The microcephalic fetus or neonate has very small amounts of cerebral tissue, and they may survive only a few hours or days. So they have very little brain tissue, and most of the time they don't have full formation of their skull either. This anomaly may be found during prenatal ultrasound, and that's where it most often is found. The mother or parent should be scheduled for an office visit at which the physician discusses the findings of the ultrasound. This is not a diagnosis that you want to give over the phone. This is not a diagnosis that any expectant mother ever wants to hear. So, this is a very sensitive diagnosis, and so we need to be very cautious in how we handle the delivery of this news. Diagnosis is made by ultrasonographic examination of the fetal head when blood tests of the mother indicate an elevated AFP level. These fetuses or neonates lack sufficient cerebral tissue to sustain life. So again, these babies typically are, if the mother chooses to carry them full term, then they will typically survive only a few hours or a few days, a very short amount of time. Oftentimes, if an anencephalic baby is diagnosed via ultrasound, they will give the mother the option to induce labor and deliver the baby early. All right, so a little less depressing, we have fetal circulation, and that's where oxygen and nutrients are supplied by the mother's blood to the developing fetus. The maternal blood supply also carries away waste products, and the umbilical vessels are what transport the blood between the placenta and the fetus. 50% of this blood passes into the liver, the other 50% bypasses the liver. The umbilical vein, a couple of notes here for you, the umbilical vein transports oxygen-rich blood and nutrients to the fetus. So I would like for you to remember that. The umbilical vein enters the fetal body by passing through the umbilical ring and then goes on to the liver. So remember that too. The ductus venosus soon joins the inferior vena cava, allowing the oxygenated placental blood to mix with the deoxygenated blood. Okay, so let me just kind of break this down for you. In adults, the inferior vena cava brings deoxygenated blood up from the lower extremities of the body and pumps it into the right atrium and right ventricle of the heart. And then it's going to go through pulmonary semilunar valves and all kinds of other business, and it heads over to the lungs, picks up oxygen, comes back in through the left side of the heart, goes through the atrium, down through the ventricles, and oxygenated blood then flows out of the aorta all the way out through the body, delivers oxygenated blood to the body. So with babies, while they're in utero, it's different. There is the inferior vena cava joins with this ductus venosus, and that allows oxygenated placental blood to mix with deoxygenated blood. So it's a little bit different with their fetal circulation. The septum primum keeps blood from going back into the right atrium. The blood is shunted away from the pulmonary circulation. Shunted away from pulmonary circulation, bypasses the lungs through the fetal vessel. So because the fetal lungs are not functioning, this blood mostly is going to bypass the lungs because the lungs aren't working the way that they're not working yet. The remaining fetal blood that has entered the right atrium contains a large amount of oxygen poor blood from the superior vena cava, and that travels to the right ventricle and into the pulmonary trunk. So that part of it is still pretty much the same. It's just that there's a lot of mixing of oxygenated and deoxygenated blood, and that changes once the baby takes its first breath. So the blood shunted from the left atrium then mixes with a small amount of blood returning from pulmonary circulation. And pulmonary circulation is where it goes out to the lungs, picks up oxygen, and comes back in. After the birth process, the infant's respiratory effort and the initial inflation of the lungs, the circulatory system undergoes changes. So here's what happens. The baby is born, takes its first breath, and all kinds of craziness starts going on in the respiratory system. The resistance to blood flow through the lungs is reduced by the inflation of the tissue of the lungs, so their lungs expanding, which allows an increased blood flow from pulmonary arteries. An increased volume of blood will now flow from the right atrium into the right ventricle and then out to the pulmonary arteries to go through pulmonary circulation. In addition, the volume of blood flowing through the foramen ovale into the left atrium is going to be reduced. So the volume of blood returning by way of pulmonary veins from the lungs to the left atrium, again, that should be oxygenated, is increased, which causes an increase in the pressure in the left atrium. So all of this basically tells you that when the baby takes its first breath, like I said, a whole bunch of crazy stuff starts happening in the respiratory system, and they've got valves that start closing that were open during while they were in utero during pregnancy, and that when those valves close and others open, that allows them to begin to breathe air and not placental fluid. Amniotic fluid. Blood is then forced against the septum primum by decreased right atrial pressure and increased left atrial pressure, and the foramen ovale closes. Okay, so the septum is the wall between that separates the chambers of the heart, and so blood pressure, the force will always be higher on the left side of the heart because that is the side. And if you ever look at a heart, in fact you can look in your textbook, if you look at a heart, the left side of it has a thicker wall. And that's because the left side is more muscular because it has to exert great pressure, enough pressure and enough force to pump oxygenated blood out of your heart and all the way down through all your body tissues. And then it gets picked up and taken back up through the inferior vena cava and into the right atrium. And that's where all of the deoxygenated blood comes in so that it can go back through and pick up more oxygen and so on. So what happens is you have a decreased right pressure and an increased left pressure, and that causes the foramen ovale to close, which is a hole. That's a hole that's there that allow blood to mix between the two. And since blood cannot be mixing anymore, since they're not in utero, that hole has to close. If this does not occur, the infant has an atrial septal defect, which is an ASD, and that will be talked about when we get further into other heart anomalies. So with the lungs expanded and taking over the function of gas exchange, the infant no longer needs the ductus arteriosus to shunt blood. So normally the ductus arteriosus closes in the first few days after birth, But there are times where the ductus arteriosus does not close, and that can cause a problem because that allows the mixing of oxygenated and deoxygenated blood still. So signs and symptoms vary according to the nature of the anomaly, the severity of the defect, and its effect on the heart. Congenital cardiac defects are developmental anomalies of the heart or of the great vessels of the heart. So acyanotic is a word that you need to be aware of, and that is when deoxygenated and oxygenated blood do not mix. The greatest medical concern for infants with acyanotic cardiac defects is congestive heart failure. That's a big deal for a little guy. That's a big deal for an adult, and even more so for an infant. Cyanotic is where oxygenated and deoxygenated blood mix. The greatest concern for infants with cyanotic cardiac defects is hypoxia. Okay, so back to that patent ductus arteriosus that I was just talking about. This results when the ductus fails to functionally close. So during normal fetal circulation, the patent ductus short circuits, which shunts the circulation from the lungs and instead directs blood from the pulmonary trunk to the aorta. So it bypasses the whole left side of the heart. So if an infant let me go back here. The infant's growth and development may be slowed if they have a PDA with various signs of heart failure. So the PDA can be detected during a physical examination when a classic machinery murmur is heard. It sounds like machinery. On auscultation and palpitation reveals a thrill. So closure may be attempted by drug therapy using an antiprostaglandin or ibuprofen. Surgical closure is also an option, like I think I mentioned 2 slides ago, that sometimes if they don't close, they can go in and have surgery and close those holes up. So the prognosis for these infants depends on the presence of other anomalies that could or could not be there, other heart anomalies that could or could not be there. Oops, sorry, I skipped one. Okay, so coarctation of the aorta is characterized by a narrowed aortic lumen causing a partial obstruction of the flow of blood through the aorta. So basically what this means is if you imagine a hose, any rubber hose, and I'm not talking about the metal part here, but if you cut the metal part of a garden hose off and you had just the tubing, just the hose, water flows through that hose, right? Because that's what you want to do. You want water to flow through. But if you squeezed the end of that hose together, water would probably flow through the top and bottom portion of it, where there's a little gap at the top, but in the middle where you had the hose squeezed together, there would be an obstruction of flow from that portion. So water would flow out in other parts where the hose wasn't completely closed off, but it wouldn't flow through where you were squeezing in the middle of it. So, and that's kind of how it is with an aortic lumen that's narrowed. So it's a partial obstruction of the flow of blood through the aorta, because the aorta is basically a big hose that carries blood out to all the tissues of the body. So if it's narrowed, then you will not have sufficient blood flow through there. So coarctation includes signs of left ventricular failure with pulmonary edema. The patient is pale and cyanotic with weakness, dyspnea, and tachycardia, all very serious signs that we need to pay very close attention to. Signs and symptoms can be evident shortly after birth, or they may not surface until adolescence. This defect, coarctation of the aorta, is often associated with Turner syndrome. Atrial septal defect is also known as ASD, and it's an abnormal opening between the right and left atria. So the right and left atria are the 2 top chambers of the heart. Although the defect can vary in size and location, blood generally shunts from left to right in nearly all ASDs. Small defects may be undetected or cause symptoms such as fatigue, shortness of breath, and respiratory tract infections. A large defect causes pronounced cyanosis, dyspnea, and syncope, so the patient faints. Classic systolic cardiac murmur can be heard with a stethoscope with ASD patients, and the condition often is associated with prematurity and patent ductus arteriosus, and closure is achieved with surgical repair. So it can be fixed with surgery. Cyanotic defects. The infant appears cyanotic with blue tinge to the lips, tongue, and nail beds. Central cyanosis, there's some notes about cyanosis here that I want you to know. Central cyanosis is a sign that the atrial blood is not fully oxygenated. The 5 main cardiac causes of central cyanosis are tetralogy of Fallot, transposition of the great arteries, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. Some defects can be detected on a prenatal ultrasound, but not all of them. In most cases, are going to be discovered during newborn exam. So deoxygenated blood enters the aorta, which causes the symptoms of hypoxia, tachycardia, tachypnea, dyspnea, and then seizures as well. Speaking of tetralogy of Fallot, it's a combination of 4 congenital heart defects. Those 4 are VSD, pulmonary stenosis, dextroposition of the aorta, and right ventricular hypertrophy. The affected infants with severe obstruction are going to be blue when they're born. So let's talk a little bit about transposition of the great arteries. The aorta and the pulmonary artery are reversed in these babies, and that results in 2 closed-loop circulatory systems, one between the heart and lungs, and the other between the heart and systemic circulation. So systemic circulation, again, is where all of the blood goes out to the tissues. Within a few hours of birth, the neonates with this defect exhibit cyanosis and tachypnea, followed by signs of heart failure. Immediate surgical intervention is indicated, and as soon as surgery is possible, the blood flow is redirected by correction of the defect. Prognosis for these infants is poor unless a pediatric surgical unit is readily available and transportation to it is swift. So lastly, we're going to talk about cardiac congenital defects. The cause for these defects remain unknown. They may result from several factors, including chromosomal abnormalities and environmental conditions. Physical examination and patient history are essential. That's where the environmental conditions come in. The physician palpates the neck vessels and auscultates for blood pressure and murmurs. So he's going to listen with a stethoscope to check the patient's blood pressure and listen for any heart murmurs. The medical management of congenital cardiac defects is determined by the type of defect and the degree of symptoms and signs. So a couple of other points here to wrap this up. Advances in surgical techniques enable surgeons to close septal defects, which are the defects in that wall between the chambers of the heart. They also allow to reconstruct or replace a valve and to repair or join blood vessels. These procedures make it possible to save, improve, and extend the lives of individuals born with congenital cardiac defects. Prognosis varies and depends on the severity, the number of defects, and the gestational age of the infant or child. Okay, so that wraps up part 2, and I will talk to you guys in part 3.